Welcome to the deep dive. Today, we're doing a focused exploration into men's health drugs. We're pulling the essentials right from your core pharmacology texts. Our mission is pretty clear. Map out the key drug classes for, well, three really common conditions: hormone deficiency, BPH, and erectile dysfunction. And crucially, highlight the safety points and nursing considerations you absolutely need for practice.
Exactly. These are huge topics. They affect so many people. We'll keep it clear. Try to make those farm concepts, like, how the body processes these things, make them easy to grasp. Think of this as your quick guide to androgens, prostate therapies, and ED meds.
Okay, sounds good. Let's start at the foundation then, testosterone. It's the main androgen, sure, but it has two really distinct roles, right? What are those?
Right. We talk about androgenic activity and anabolic activity. Androgenic is probably what most people think of, first developing and maintaining male characteristics. Things like hair patterns, deeper voice, prostate growth. But then there's the anabolic side. That's the building part. It helps develop muscle and bone, inhibits protein breakdowns so tissues can repair, and it makes the body hold on to nitrogen, potassium, sodium. Oh, and there's also an erythropoietic effect. It stimulates red blood cell production, sometimes used for certain anemias because of that.
That dual action makes sense, explaining why they're used for low T, but also, like, stimulating appetite after trauma. But administering it, that's tricky. Taking it orally doesn't work well.
Yeah, that's a classic pharmacology problem. It's the liver. When you take natural testosterone by mouth, it goes straight to the liver from the gut. And the liver is so efficient at breaking it down, that's the first pass effect, that almost none of the active drug gets into your system to actually work.
Okay, so if swallowing a pill is mostly out, how do we get therapeutic levels? What are the workarounds?
Well, there were basically two paths. First, chemists tweak the molecule itself, made synthetic versions like methyltestosterone. These are designed to resist that liver breakdown, so you can take them orally or buccally. But probably more common now are the methods that just bypass the liver completely. Think long-acting injections like testosterone cypionate that you get every 2-4 weeks. Or the transdermal systems, patches and gels, androderm, androgel, testosterone, those are really widely used.
Right, and this brings us to anabolic steroids, like oxandrolone. They have legit uses, like for weight gain post-surgery. But there's a big safety concern: Schedule 3 classification.
Absolutely. That Schedule 3 status flags the high potential for abuse, particularly, by athletes. And the misuse risks are severe. We're talking sterility, liver cancer, serious cardiovascular problems. It's not trivial.
And even for legitimate uses, all testosterone therapies have that big warning, the
Oh,
black box warning. What's the absolute key alert there?
The black box is about thromboembolic events. So blood clots, DVTs, PEs, and also increased risk of heart attack and stroke. A history of clotting is a major red flag when considering these therapies. And beyond just general liver toxicity, there's this really scary long-term effect called peleosis of the liver.
Peleosis, what's that?
It's where these blood-filled cavities, like little sacs, form randomly in the liver. Super dangerous because they can rupture and cause massive internal bleeding. It's why monitoring liver function tests regularly is just non-negotiable for anyone on long-term androgen therapy.
Okay, that serious liver risk is a good pivot point. Let's shift from hormone replacement to a structural issue often driven by hormones: benign prostatic hyperplasia, BPH.
Right.
This is the non-cancerous prostate growth that, wow, affects up to 85% of men by age 80, causes urinary blockage.
And the main drug class tackling the cause of that growth is the 5-alpha reductase inhibitors. Finasteride and dutasteride are the key ones here.
So walk us through that mechanism. How does blocking just one enzyme, 5-alpha reductase, actually shrink the prostate? What's the link?
It's quite targeted, actually. Normally, this enzyme takes testosterone and converts it into a much more potent form called dihydrotestosterone, or DHT. DHT is basically the primary fuel for prostate cell growth. So these drugs block the enzyme, DHT levels in the prostate drop, and without that constant stimulation, the gland physically shrinks over time. That relieves the pressure on the urethra.
It's interesting how finasteride has that dual personality based on dose. 5 milligrams Proscar for BPH, but just 1 milligram is Propecia for hair loss.
Yeah, it's a great example of how the same mechanism blocking DHT can have different effects depending on the target tissue. Stops prostate growth and helps prevent hair thinning in the follicles. But this immediately brings up a critical nursing point, the teratogenicity alert.
Right, pregnancy category X. That sounds serious.
It is absolutely serious. Pregnant women, or women who might become pregnant, must not even handle crushed or broken finasteride tablets. The drug can actually be absorbed through the skin and cause severe birth defects in a male fetus. So gloves are mandatory if a female caregiver has to administer it. Really hammer that point home.
Okay, super important. Now, finasteride works by shrinking the gland, but you mentioned that takes time, right? Like months.
Yeah, it's a slow burn. You're looking at 3 to 6 months for the full therapeutic effect on prostate size and urinary flow.
So what about guys who need relief now? They can't wait 6 months if they can barely urinate.
Exactly. That's where the alpha-1 adrenergic blockers come in. Drugs like tamsulosin Flomax or doxazosin. These don't shrink the prostate at all. Instead, they work on the smooth muscle in the prostate capsule itself and around the bladder neck. They relax that muscle. Relaxing the muscle reduces the constriction on the urethra, so urine flows more easily. The relief is pretty much immediate. It's a key difference. Flomax for quick symptom relief, finasteride for long-term size reduction.
Got it. And just to differentiate, there are other anti-androgens like flutamide or leuprolide. They sound related, but are used differently.
Right. Those are primarily heavy hitters for prostate cancer. Flutamide blocks androgen receptors. Leuprolide shuts down testosterone production systemically. Their goal is different, basically starving the cancer of hormones. We mention them here just to make sure we distinguish them from the BPH treatments. They're not typically for benign enlargement.
Okay, clear distinction. Let's move on to the third major area, erectile dysfunction, or ED. The sources say it's quite common, maybe affecting over half of men in some form, especially with conditions like diabetes or hypertension.
Yeah, the prevalence is really high, and it definitely increases with age and those comorbidities. The go-to pharmacological treatment class is the phosphodiesterase 5 inhibitors, the PDE5 inhibitors. Sildenafil, which is Viagra, was the first one, the groundbreaker. Then came others like tadalafil, Cialis, vardenafil, avanafil.
So the mechanism, inhibiting an enzyme called PDE5, how does that lead to an erection? Walk us through the steps.
Okay, so normally during sexual arousal, the body releases nitric oxide, which leads to the production of something called cyclic GMP, or cGMP. cGMP is the chemical messenger that tells the smooth muscles in the penis to relax, allowing blood to flow in and cause the erection. The PDE5 enzyme's job is to break down that cGMP fairly quickly. These drugs block PDE5. So cGMP doesn't get broken down as fast, it builds up, stays around longer, leading to more sustained, smooth muscle relaxation and better blood flow into the corpora cavernosa. And this is key, it only works with sexual stimulation. It enhances the natural process. It doesn't just cause an erection spontaneously.
Right, it requires arousal. Now, the absolute must-know safety issue here, the critical contraindication.
This is the big one, life-threatening. PDE5 inhibitors absolutely cannot, under any circumstances, be taken concurrently with nitrate medication.
Nitrates like nitroglycerin for angina.
Exactly. Nitroglycerin, isosorbide mononitrate, isosorbide mononitrate dinitrate, any form of nitrate. Taking them together causes this massive synergistic drop in blood pressure, profound hypotension that can be fatal and often doesn't respond well to treatment. You have to screen for nitrate use, period.
Got it. Critical warning. Thinking about sildenafil specifically, the kinetics works relatively fast, lasts a few hours.
Yeah, onset is usually within 30 to 60 minutes, peaks around an hour, duration is maybe 4 to 6 hours, but patient factors matter. Taking it with a high-fat meal, that can significantly delay absorption and when it peaks. Also, older adults, say 65 plus, often clear the drug more slowly because of age-related kidney or liver changes. That means it sticks around longer, increasing the risk of side effects or toxicity. Dose adjustments might be needed.
We've covered the huge hypotension risk with nitrates. What about more common side effects? And is there anything rare but urgent?
Common ones are things like headache, facial flushing, maybe some indigestion or dyspepsia, usually manageable. The rare but urgent one is priapism. That's an erection that lasts way too long, typically defined as more than 4 hours, and it's often painful. This is a medical emergency. Patients need to know that if an erection lasts longer than 4 hours, they must seek immediate medical help to prevent permanent damage to the tissue. And just briefly, there is an alternative, alprostadil, it's prostaglandin, different mechanism.
How's that one used?
It's not a pill. It requires either injecting it directly into the erectile tissue or inserting a tiny suppository into the urethra. It's usually for guys who can't take the oral PDE5 inhibitors for some reason.
Okay, that covers the major drug classes. Let's tie this together with the nursing process. What are the key assessment points and implementation tips?
Okay, assessment first. For DPH, you're obviously assessing urinary patterns, frequency, stream strength, urgency, nocturia. If they're on finasteride, you're tracking PSA levels. They should go down if the drug is working. For testosterone, remember the risks. Monitor liver function tests, look for jaundice, check the labs. Also, baseline weight and intake output, because fluid retention can happen. And for ED drugs, the absolute must-do is that thorough cardiac history and medication reconciliation, specifically looking for any nitrate use.
And when it comes to actually giving the meds, especially those testosterone patches or gels, the application instructions seem really specific.
Oh, they are, and getting it right matters for effectiveness and safety. For example, the Testoderm patch goes only on clean, dry scrotal skin. But the Androderm patch goes on the back, abdomen, upper arms, or thighs, never on the scrotum or bony areas. Big difference. And with the gels or sprays, the major teaching point is preventing transfer to others. Wash hands thoroughly immediately after applying. Don't let partners or kids touch the application site until it's dry and covered.
What about key teaching for the finasteride patient, besides the handling precautions for women?
Definitely reinforce the timeline. Let them know BPH relief takes 3-6 months so they don't get discouraged and stop early. Reiterate the pregnancy warning gloves if handling broken tabs. And always, always teach the 4-hour rule for priapism if they're also taking any ED medication. Immediate medical attention needed.
Okay, and what about herbal options? Saw palmetto comes up a lot for prostate issues.
Yeah, saw palmetto, Serenoa repens, is really popular for BPH symptoms. The thinking is it might inhibit DHT or 5-alpha reductase, sort of like finasteride, but maybe less potent. Clinically, the important thing is even if a patient chooses an herbal route, they still need a proper workup first, a digital rectal exam, a PSA test to rule out prostate cancer. And tell them to be aware of potential interactions, especially with NSAIDs or any hormone therapies they might be taking.
Okay, great overview. So quick recap. Androgens like testosterone for deficiency or muscle wasting. 5-alpha reductase inhibitors like finasteride for shrinking the prostate in BPH or for hair loss. And PDE5 inhibitors like sildenafil for ED.
Exactly. And if you remember just one critical safety point from all this, make it the PDE5 inhibitor and nitrate interaction. That risk of severe, potentially fatal hypotension is paramount.
And as we close out, the source material brought up an important point about disparities. Prostate cancer is the most common cancer in men, barring skin cancer. But African American men have the highest rates and are more than twice as likely to die from it compared to other groups. That's a stark difference.
It really is, and it raises a deeper question for us, doesn't it? Beyond just knowing the drugs and how they work, how does our understanding of pharmacology intersect with these larger issues of health equity, disease prevalence, and mortality rates across different populations? Something important to keep thinking about as you move forward in practice.